Okay, can you see my screen? Can you see my screen? Yes or no, guys? Tell me quickly.
No, sir.
You
No,
can't
sir.
see my, I'm not
No,
sharing?
sir.
Oh,
No.
okay. Share screen. Share screen. Blue one. Share. Okay. Can you see my blue screen now?
Yes.
Yes, sir.
Okay. Now can you see rhythm written?
Yes, sir.
Okay. All right. So let's go back into the rhythm quickly. Now we'll move fast because we've done the ECG. We understand it. So whenever you say a sinus rhythm of an ECG, there should be a P wave. The P wave should be round shape. It should always have the same shape. There should be no change in the shape. Each P wave has to be followed by a QRS. The PR interval has to be 3 to 5 small squares and constant, and the rhythm should be regular. Okay, so that is the key thing for a sinus rhythm. We said yesterday the P wave is coming towards the lead 2. So P wave is always upright in lead 2, and P wave is inverted in AVR. Okay, so that is sinus rhythm. When you see P wave upright, then we know that. So this is a sinus rhythm, nice P, Q, R, S, and T. This is the rhythm strip. Everything is looking okay, no problem. This is a sinus rhythm. P followed by Q, R, S, T. Very, very clear cut. Yesterday we said there is, if there is a problem, it can be supraventricular or infraventricular. Supraventricular means the foci is somewhere else in the atrium, okay? So above the ring of the ventricle, or the foci above the ring ventricle causes supraventricular problems. The foci below causes ventricular problems, okay? So this is a rhythm chart. Whenever you see whenever you see an ECG, you have to see the ECG in 12 leads, but more importantly, you've also got to see the rhythm strip. Okay, the rhythm strip is very important, and you must always go in this order. You must always look for the rate, you must look for the rhythm, look for R to R thing, which gives you the rate, look for the P wave, look for P to QRS transmission, which is the PR interval, and then look for the QRS. So let's look at the ECG and try to understand it. So the rate is 150 beats per minute. The rhythm seems to be regular. The P waves are difficult. I can't see P waves here. Can you see that? I can't see P waves here. Very difficult. We have got the rate on the basis of the number of large boxes. Okay, so 2 large boxes, so the rate is 150. P waves are difficult. QRS seems to be normal. So this is either a sinus tachycardia, or it is an SVT, or it's an atrial fibrillation. So it is not fibrillation because we know that the rhythm is normal. In a fibrillation, the rhythm is not normal. So we know that this is either a sinus tachycardia or an SVT. In that situation, what you have to do is you have to stimulate the vagus or the carotids. When you stimulate the carotids and the heart rate goes down, you know you're dealing with an SVT. If it's a sinus tachycardia, then you have to give fluids to challenge the patient and bring down the sinus tachycardia. In addition to that, if the vagal stimulation is not working, then you give adenosine. If you give adenosine, then the heart rate comes down on the ECG. You know you are dealing with an SVT. So this was the analysis which I showed you yesterday. Again, this is yesterday's slide, so I'm just going a little bit faster. So here is another ECG. We have to calculate the rate. Rate is 66 beats per minute. Number of R waves in a 10-second rhythm strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So 11 into 6 is how you do it. So 11 into 6, so rate will be 66 beats per minute. Then you look at the irregularity. See, QRS is okay. QRS is coming quite okay, but look at the P waves. There's really this sort of fibrillatory movement in this P wave. Something is not right in the fibrillatory. See here, again, fibrillatory movements in the P wave. So we know that this is a supraventricular problem. We know this is coming from the atria, and it's more likely to be an atrial fibrillation because the P waves are not clearly seen. And more importantly, we are seeing fibrillatory waves. These waves are called as fibrillatory waves, and that is atrial fibrillation. Okay. All right. So we have spoken about this yesterday. I won't waste time on that. So let's look at this ECG. Have a look at this ECG. No P waves, really can't see the P waves very well. Maybe there, maybe not there. Yeah. Here there is no P wave. The baseline is going up and down. That is the important thing. The baseline is changing. The QRS is changing the rate. So here it is okay, here it is slow. So there is a real change of the QRS rate from one end to the other end. So there is definitely some problem happening here. The QRS shape is not okay. The T wave appears to be normal. In all of this, look at the T waves are normal. There is no problem with the T waves. So this is probably an atrial fibrillation because the P wave is fibrillatory, is absent, and it's causing the rhythm to go up and down. Okay, let's look at this one. This is a very, very good one. This is quite classic. The rate, again, you calculate exactly the same way. So the rate works out to 150 because there are two large R's between two QRSs. So that's about 150, 300 by 2. The rhythm is regular, okay? So there is no irregularity of the rhythm. Two waves, two boxes, two boxes, two boxes, two boxes. So regular rhythm. But P wave is not very clear. There's something the P wave is not very clear. Okay, it's really a problem here. QRS T, but what is happening here? The P wave is not very clear. But more importantly, it is sort of sawtooth. Can you see this sharp sawtooth thing? So this sawtooth thing is called as a F wave. Okay, and the F wave is usually representative of atrial flutter. It will become clear in the next slide. Look at this. This sawtooth, this sharp sawtooth, this is a F wave. And this F wave is called as atrial flutter. Classic, seen in lead 2, AVR, and V1. Okay, classic. It is always called as F wave. And whenever you see this sharp up spike, then think of the saw, the teeth of the saw. And again, the ratio can be 1:1, 2:1, 3:1. So you can have one P wave followed by one QRS, or you can have two P waves followed by one QRS, or you can have three P waves followed by one QRS. So P, the atrial rhythm is different and the ventricular rhythm is different. So in this, if you want to calculate the ventricular rhythm, you have to calculate 1, 2, 3, 4. 4 boxes. So the ventricular rhythm is 300 divided by 4, which is 75. But atrial rhythm is really fast. So you have to calculate the number of P waves between on a 6-second rhythm strip or a 10-second rhythm strip. And then you multiply it. If it's a 6-second rhythm strip, you multiply the number of P waves by 10. And if it's a by 6, if it's a 10-second, you multiply by 6. If it is a 6-second, you multiply by 10. Okay. So once you have done that, so you get the P rate is different and the ventricular rate is different, and that gives you an idea of the block. So the ratio of the block depends upon atrial rate, the number of atrial beats versus the number of ventricular beats. That is what gives you the block, because atria is contracting, 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 but all the atrial contractions are not going to the ventricle. So that is called as a block. Okay. So again, I'm going a little fast because we did this yesterday. All right. Come on, what's happened? The most common in atrial flutter is a 2:1 block. All right. So most important, the most common is a 2:1 block. And this is classical atrial flutter. Again, this is a classical atrial flutter. Okay. All right. Again, another one, classical atrial flutter. Sharp peak with separate QRS, separate. So the P wave rate is separate, the QRS rate is separate. And if you calculate the QRS versus the P rate, it will be turn out to be a 2:1 block. And this is a classical atrial flutter. Okay. All right. Here there is one QRS. There's one QRS, but there's nothing. There's a huge gap here. Okay. The assay fails to depolarize, and there is a delay. An abnormal P wave is seen. Okay. Abnormal P wave is seen. Okay. So something is not right. Abnormal P wave, but it is followed by a normal QRS. So this space, this fellow is creating its own P wave. Normal SA created a P wave, so you got this QRST. But this fellow created another P wave, and that is an abnormal P wave, which is not followed very well by a QRS. So this again returns back to sinus. Can you see that? So this is returning back to sinus. This is called as atrial escape. So whenever a separate foci of P wave creates an unusual P wave that is called as atrial escape. Okay. Again, this is ventricular escape. Here you've got normal QRS, normal PQRS, and suddenly one QRS is coming into the picture. This is not a normal QRS, okay? So because this is not a normal QRS, it means that something is happening within the ventricle which is stimulating an abnormal QRS within your ECG rhythm. And because of this, after 3 normal sinuses, there is an abnormal QRS. This is called as a ventricular escape. So when you get an extra ventricular beat, not preceded by a P wave, that is called as a ventricular escape. When you get an abnormal P, not followed by a QRS, that's called as a atrial escape. So atrial escape and ventricular escape, that's what you have to see. Now let's look at this one, okay? So this is PQRS-T, PQRS-T, but look at what's happening here. Suddenly we've got a lot of QRS complexes coming. There is no time for T to be seen. There is no time for the repolarization to happen. So after 2 sinus beats, the heart rate has increased to 200. The QRS has become broad. Okay, there's a broad QRS. And most importantly, the T wave is difficult to find. We're struggling to find the T wave in this one. And then again, it is returning to normal. Okay, so what is happening in this? This is called as ventricular tachycardia. Okay, so this is ventricular tachycardia, not atrial. This is a ventricular tachycardia because it's the QRS which has got affected. And because the QRS is higher potential than an atrial, even though the atrium is still contracting in this, you're not seeing any P waves in this because the ventricle is taken over. The electrical activity of the ventricle is much higher on the ECG strip, and so it is completely taken over. You cannot see any P waves in this. And most importantly, you cannot see any T waves because there's not enough time for the repolarization to show itself on the ECG strip. Okay, so this is ventricular tachycardia. Okay, so this is a 12-lead ECG. Let's have a quick look analysis of this ECG. So there is no P wave in this. The QRS are regular, and if you calculate the rate will come out to 200 beats per minute. The ECG is broad, okay? Broad QRS. The QRS is broad. The duration, if you calculate, is almost 280 milliseconds. It's quite a large thing. The shape is also abnormal. This is not how QRS is supposed to be. There is no identifiable T wave, okay? There is no identifiable T wave. But it is still in a sort of a rhythm. There is no sort of, it's not a haphazard rhythm. So this is called again as ventricular tachycardia. So this is how a 12-lead ECG of a ventricular tachycardia will look like, okay? Now this is different from the previous one, okay? This is the previous one. This is different from the previous one. In this, the rhythm has gone chaotic. The ventricle is doing what it's supposed to, is not doing what it's supposed to do, and intermittently it's going all over the place. Look at that. It's all over. The baseline is also not maintained. The rhythm is not normal. There is a chaotic rhythm. The rate is also chaotic. Sometimes 200, sometimes 75. The P wave cannot be seen because the ventricular activity has taken over the whole ECG. The PR interval, there is no PR interval. You cannot see it at all in this. The QRS is chaotic. In some places it is absent. In some places it is completely chaotic. And this is a classical picture of what we describe as ventricular fibrillation. This is ventricular fibrillation. In ventricular fibrillation, the patient is going to arrest or is already arrested, okay? So you really need to act fast and defibrillate this patient. So very important. This is ventricular fibrillation. The previous slide was ventricular tachycardia. So there's a difference between ventricular tachycardia. Ventricular tachycardia, if not treated, will quickly go into ventricular fibrillation and the patient will arrest. Okay, so it's very important to differentiate the two. All right, look at this. This is the reason why ventricular fibrillation happens is multiple sources. All these stars start to fire and all of it becomes very chaotic and the patient will arrest very, very soon. Let's look at this ECG. Is it making sense or am I going too fast?
It's making sense, sir. It is good, sir.
Yeah, because we did this yesterday, so I'm not wasting too much time on it. So calculate the rate on the basis of RR interval. There is a right axis deviation. I showed you yesterday how to calculate the right axis deviation. The PR interval is quite short, okay? Look here, the PR interval is almost, we can't even make out here the PR interval. This is a very classic ECG, okay? Because what you see here, look at this. This is the key thing. This thing going upwards, this curve of this ECG going upwards is called as a delta wave, okay? The slurred uptake, this is called as delta wave. And you can see this in 3, you can see this even here in V4, you can see this in V3. This upward slant is very classical. This ECG is kept in the exam, okay? And this usually suggests a WPW, okay? Wolff-Parkinson-White syndrome. So this presence of a delta wave, okay, and right axis deviation is usually indicative of WPW. Okay, so this is what happens in a WPW. There is a extra focus of stimulation which causes what is called as a re-entry tachycardia. So you can't really see the P waves. Again, see in this one, slurred uptake. Yeah, slurred uptake. So that's a delta wave. Yeah. So this is again WPW. Another example of the slurred uptake. This curve is very important. See this curve? There is the PR interval is grossly shortened. There is no PR interval, and there is this curved uptake of the ECG. This is called as delta wave. So very important. Again, here you might appreciate a little bit here. Okay. All right. So this is how you do the whole analysis, okay? Whenever you sit with an ECG, you have to do this whole analysis like this. You have to go through everything and try to understand all the problems that are happening, go through the rate, go through the rhythm, go through the RR interval, whatever is happening, and then you come to an answer of what is happening, okay? So I just showed this for you. This is WPW. I spoke about this yesterday. What is this? Okay, sorry, let me just come here. Okay, so again, in this ECG, look what is happening here. What is this? The P is there, but something is spiking. Can you see that? These spikes, these regular spikes, these are pacemaker spikes. So occasional P waves, not related to QR, but there is a QRS preceded by a brief spike. The spike is always indicative of pacemaker. Okay, so the pacemaker stimulus is seen, and this is actually a pacemaker spike. Okay. Sorry, what's happening? And this is the pacemaker stimulus. All right. So whenever you're dealing with rhythm issues, always treat underlying cause. Extrasystoles do not need treatment, but whenever you are in acute heart failure or severe hypotension, always think of DC cardioversion. If you go into bradycardia, then think of atropine and pacing. Okay, so that's important. I spoke about the carotid sinus massage the other day, and I spoke about the management with adenosine. Okay, it's important to differentiate between the two. So this is the chart. Please take a snapshot of this chart and try to understand it. And this chart actually gives you the idea of how to diagnose rhythm problems. Okay, so this is a very, very good chart. But you have to look at P wave present or absent. You have to look at the PQRS, the PR ratio, whether it's normal, it is extended, or is it QRS is absent. And the whole thing, if you follow this chart, you can make any diagnosis on the rhythm problems of an ECG. Okay, so that's where we had stopped last time. Now let's look at conduction defects. Okay, so conduction defects are very easy to understand. Okay, conduction defects, there are only 4 or 5 problems that you have to know in an ECG which comes in the exam. The first one is a first degree heart block. The second one is a second degree heart block. And second degree heart block are 2 types, Mobitz type 1 and Mobitz type 2. And then you've got the third one, which is a complete heart block. And then in addition to that, we've also spoken about right bundle branch block and left bundle branch block. You remember the diagram of the AV node and the bundle of His, and the right bundle and the left bundle. Okay, so these are the various types of ECGs that you will look at. Now, I will take you through each one of these and show you what is happening. Okay. So what do you think will happen in a first degree heart block? In a first degree heart block, there is one PR per QRS. Okay. So the P is there, the QRS is there, the T is there. Completely. Regularly, if you look, there is a P, there is a QRS, there is a T. All along here. There's a P, QRS, T, P, QRS, T. But what is happening is the PR interval. This is becoming prolonged. Okay. And the last time when I did the lecture on ECG, I did tell you that a PR interval always denotes the AV bundle. Okay. The PR interval denotes that there is slow conduction in an AV bundle. Okay. Remember the upward spike and downward spike and a flat line. And I said that a PR interval denotes slow conduction in an AV bundle. So when you have a prolonged PR, look, the PR is prolonged. This is much, much longer, 360 milliseconds. Yeah. So this is a prolonged PR. So whenever you have a prolonged PR, it's called as first degree heart block. It's as simple as that. Not difficult at all. Calculate the PR interval, and you know if a PR is prolonged, it is a first degree heart. Okay. So one P wave per QRS and PR interval greater than 200 is always called as first degree heart block. Is it okay? It's very, very simple. It might be seen in normal people as well, but if it does happen, you have to think about MI, you have to think about rheumatic fever, but you really don't need to treat it. There is no problem with that. Okay. You don't need to treat it. So let's look at this one. This is a nice ECG where let's go through one first. Okay, so this is P, PR, QRS, T. Okay, but here if you calculate the number of small squares and you multiply it by the formula, you get 260 milliseconds. Now the next one, if you calculate the number of small squares and you multiply, because one small square is 0.12 seconds. So again, this is 280 milliseconds. Look at this one, this is increased, there's 320 milliseconds. And then the fourth one is not followed by a QRS. Yeah. So there is progressive increasing PR levels in this ECG, and then a drop of the QRS. So whenever you have a progressive lengthening of a PR interval and one non-conducted P wave, and if you look again, the same cycle is starting. So next conducted beat has shorter PR than the preceding. So this was 320. Look at it. Here the beat has come back to 260. So again, the next conducting beat has a shorter PR than the preceding beat. This is quite classic of second degree heart block, Mobitz type 1. Okay. So the P wave may show itself as a distortion of the T. That's what they're saying, that sometimes the P wave and the T wave come together. So there could be distortion of the T. But this, a prolonging PR interval on an ECG and drop of one QRS after a period of prolongation, and then the next PR is less than the preceding one, is called as Mobitz type 1. Okay, so it's called Wenckebach or Mobitz type 1, which is progressive PR length, then a non-conducted P wave, and then repetition of the cycle. Is it making sense? Yes or no?
Yes, sir. Yes, sir. Yes, sir.
Yeah, is it okay? Do you want me to go at this pace or fine?
It's okay, sir. It's okay, sir.
Okay, so now let's look at this one. The PR interval, where is the PR? This is the PR. The PR interval of the beat is constant, but one P wave is not followed by a QRS complex. Yeah. In the previous one, the P wave was increasing. Yeah. But in this, one P wave has dropped. Okay. So this is also a type of second degree heart block, but it is called as Mobitz type 2. Okay. So there is occasionally there's a non-conducted beat. Okay. And the block could be 2:1 or 3:1. So depending on 2 PRs followed by a non-QRS or 3. So it's called as 2:1 or 3:1. So there may be 2 or 3 P waves per QRS complex, but with a normal P wave rate. Okay, so that's called as Mobitz type 2. Mobitz type 2, whenever you get a second degree heart block, usually indicates heart disease. There's some problem. First degree may be normal. In some physiological people, in some people, physiologically, you may actually get first degree heart blocks. But whenever there's a second degree heart block, think of MI. Okay, there's something happening which is affecting the AV conduction into the bundle of haze. Okay, so it is the conduction of AV to the bundle of haze, and usually MI. Okay, they may not need specific treatment for rhythm, but you have to treat the underlying cause. But if the degree of heart block increases, so from 2.1, it is 2:1, it's going to 3:1 or 4:1, sometimes you might actually need to give them temporary pacemaker. So you might have to float a pacemaker wire, or you might even have to put in a ventricular a permanent pacing box if the ventricular rate is very slow and not enough to create enough blood pressure. So this is the indication of this. Okay, all right. Now let's look at the next ECG. Okay, there are 2 P waves per QRS complex. Can you see that? 1 and 2. Yeah, 2 P waves and 1 QRS. Again, 1 P and 2 P. This is getting merged with the T, but definitely there's a bump, a separate. So 2 P waves with 1 QRS complex. 2 P waves with 1 QRS complex. Okay, normal and constant PR interval in a conducted beat. Okay, so this is a second degree heart block. Yeah, it's very simple. It's second degree heart block. So 1 P wave is not conducting, and then 1 P wave is conducting. So this is a second degree heart block, but the important thing is 2:1. This is how you say 2:1. Let's look at another one. There is the P wave within the T. Yeah, you can see this P wave, you can see this P wave. Again, sometimes the P wave gets fused with the T, but this notch is not normal in a T wave. So this is actually a P wave. So this is 2 P waves in 1 QRS, but the P wave is getting hidden by the T wave. You can see that very clearly. This is also second degree heart block, 2:1. Okay. All right, let's look at the next one. Okay, look at this ECG. The P wave is at 90 per minute, so you calculate the number of P waves and you multiply it. The P wave and the QRS has no relation. See, there's nothing in between here. So here suddenly there is a large PR. Can you see this? Here there is a normal PR. Here there is a large, I don't know what the hell. The PR has gone really. So there is no correlation between the P and the QRS in the rhythm strip. The P is not followed by QRS. Here there is a normal P followed by a QRS. Here there is a normal P but a long PR interval. So whenever you have no relationship between P and QRS, and the ventricular rate is slower, much slower than the P, than the atrial rate, then you have to worry about it. Okay, the QRS is also slightly abnormally shaped. Then you are dealing with a third degree heart block. A third degree heart block is because there's abnormal depolarization because of a ventricular focus. So there's a complete loss of correlation between P and QRS. Can you see this? Here the P is followed by QRS, but here suddenly the QRS has come on its own. So there is no conduction happening across the AV to the bundle branches. There is some problem in the bundle of haze, and this is a third degree heart block. Third degree heart block is not good. Okay, you really always, a third degree heart block will need pacing and unusually wide QRS complex. The QRS rate is very low, so the ventricular rate is much lower than the atrial rate, and it will be very narrow, usually less than 50 to 60 beats per minute, and that is a third degree heart block. This indicates that the conducting tissue is diseased. Usually indicates fibrosis rather than ischemia. Ischemia usually causes first degree or second degree heart block. But when there is disease in the fibers within the bundle of haze, that is not good, and that usually will need a permanent pacemaker. Okay, so is third degree heart block okay? Understood or not?
Yes, sir. Yes, sir. Yes, sir.
Yeah, it's not difficult as long as your concept of PQRS is clear. It's not difficult. Okay, let's look at the next one. Okay, so look at this one. I will just analyze it for you. So P wave is there. Okay, P wave is there, but nothing is happening. What the hell is in nothing? Only P waves are coming. Yeah, the P wave rate, if you calculate the rate and you do on a 6-second strip, it is 145 per minute. But the QRS is not coming, and when it is coming, it's very abnormal. Can you see that? Exceedingly abnormal. This is not the normal way QRS is supposed to look. And if you look at the rate, if you calculate the rate, it's 15 per minute. The QRS rate is 15 per minute. And there is no relationship between the P wave and the QRS. And this is indicative of third-degree heart block. Okay? So very important to understand this. Third-degree heart block always needs a permanent pacemaker. Okay? So this is exactly what happens. Look at this again. This is the whole analysis is given at the bottom. This is complete heart block 2:1. Okay. All right. Now let's look at the bundle branches. So this is the diagram which I should have had before. So AV, bundle of His, left bundle branch, right bundle branch. Okay. So what will happen if there is a right bundle? So see, this is cut off. This is, when this is cut off, this is called as a right bundle branch block. Okay. So now this is a very classic pattern, very classic. If this comes in the exam, you're happy because you can diagnose this straight away. I'll show you what's happening. Okay. So in a right bundle branch block, you get what is called as an RSR in lead 1. Okay. In lead V1. RSR1 in lead 1. Okay. Just remember this for a minute. I'll explain to you how the RSR comes. And in a left bundle branch, you get a letter M in lead V6. So V1, you know, is in the second intercostal space. Yeah, sorry, is in the fourth intercostal space to the right of the sternum. Okay. And we know V1 and V2 is looking at septum. I explained that yesterday. The V1 and V2 lead is looking at septal depolarization. Okay. So what will happen if there is a problem with the right? See, the right bundle is cut off here. There's a block of the right bundle. So when the action potential reaches the AV node, comes down the bundle of His, it goes down preferentially down the left bundle. So we know that the left actually depolarizes the septum from the left to right. Yeah. So when it depolarizes from left to right, if you're looking at this from V1, this is V1, we know is a positive lead. It's a unipolar positive lead. So when this action potential is coming towards the positive lead, there will be an upward spike. So that is the first part of the R. Okay. Now, what will happen is then this action potential will go down the ventricle. Okay. And preferentially will go down the left ventricle because more mass. The right one is blocked. It's preferentially going down the left ventricle. So there is this downward spike. Yeah. Downward spike. And then the right ventricle still has to depolarize. So after this is depolarized, it will come back to the right ventricle. So you got the R, you got the S because it went away from the lead V1. And most importantly, now the right ventricle is starting to depolarize. And so you get another R. Okay, so there is R and R dash. Okay, R and R1. So you get an RSR1. Did you understand this? Hello?
Yes, sir.
Yes, sir. Yes, sir.
Yeah? So let me do this again. Okay, right bundle branch. Here is the right bundle. The right is blocked away. The septum is depolarizing. The movement is from left to right. So you get the first R. Now the thing is moving down the septum and going up on the left side, which is normal, which it's supposed to do. So that you get the S. But instead of getting your T now, ST interval, now the right ventricle will have to depolarize after because this one is blocked off. So this gets depolarized and then it comes back towards the right. So you get another R. So this RSR pattern in lead V1 is very, very classic of a right bundle branch block. Okay, is the best one to pick up, a right bundle branch block. Okay, now let's look at these things. Look at the ECG. Okay, have a look at the ECG. Take your time and try to understand it. So this rate is normal. It's a sinus rhythm. The rate is 60 per minute. The PR interval is normal. There's no problem with the PR interval. PR interval may be okay. Look at this. PR interval is okay. Let's concentrate on V1. PR interval may be there. There's a P wave here. But look at the V1, okay? Look at this deflection. There's a small upward deflection which is reflecting septal depolarization. Then there's a downward deflection which is representing left ventricular depolarization because it's going away from ventricular 1. And then look at it. It's coming back towards the right ventricle in a big way. So septum, ventricular, and right ventricle coming back towards the right ventricle in a big way. Okay, so this is called as the RSR. The axis is normal. We calculated that. The QRS is widened because it is taking more time for the ventricle to depolarize. Because if the right bundle branch is blocked off, then the action potential has to go down the left side, depolarize the left side, then come back and depolarize the right side. So the QRS becomes widened. There is a widening of the QRS and you get this classical RSR1, okay, in V1. And if you look in V6, which is an opposite, there is a wide S wave, okay? So a wide S wave in V6, which is the opposite of what was happening in V1, is representative of right bundle branch block. Okay, now let's look at left. So this is sinus rhythm with right bundle. This is classical. If you get this in the exam, you're winning. Okay, so this V1, V2 is still representing the same thing. Look, V3 is also showing it. So this depends on where they have placed V1, V2, and how well that ECG has been taken. So classically, it should be seen in V1, but it can be seen in V2 and V3 as well. If you bring the V2 and V3 closer to the right side, it will show you a right bundle branch block. Okay, all right. Now let's look at left bundle branch block. See this diagram in the middle. So your AV node is depolarized, bundle of His is depolarized, but now the problem is there is no conduction going down the left bundle because it's disease. So the left bundle branch is gone. So the right bundle branch is depolarizing. Now it is going opposite. The septum is now depolarizing from right to left. Yeah, because the left is gone. So the septum is depolarizing from right to left. Because it is depolarizing from right to left, look at V6. We are now going, because V6 looks at it from the left lateral. Yeah, V6 is here. So it always looks at the ventricle from the left lateral side. So this is going towards V6. So you get this spike. Then look at what's happening. It's coming here and going away. Okay, it's starting to go away. So you get this little bit of S wave, which is starting to happen. But predominantly, the right is done, but predominantly it's then pushing towards the left. Okay, so the little bit of notch is because the right ventricle, the little bit of notch was because the right ventricle started to depolarize. The left, it didn't reach straight away, but then the surge will turn around and move towards the left ventricle. So you get this notch, you get this little bit of notch of right ventricular depolarization, but then the whole action potential turns around and aggressively depolarizes the left ventricle. So you get a very large notch, which is an R. So this is an M pattern. Can you see that M pattern on a V6? So if you get an M pattern on a V6, classically it is left bundle branch block. Look here, V6, V5, V6. Okay, both of these are looking at it from the other side. So look at this. Can you see this? So your septum is depolarizing. Then your right ventricle is starting to depolarize. So this is going away. But then the action potential turned quickly and moved towards the left ventricle. So purely by looking at one bit of the QRS, you can actually understand what is happening on the heart, on the myocardium. So this is the septum depolarization. This is the right ventricle depolarization. This is the left ventricle depolarization. And so you're getting this complex of a M wave. So sinus rhythm rate is 100. The PR is normal. That's not a problem. The axis is normal. You can calculate that. I showed you yesterday. But the QRS is again wide. It is wide because it's taking more time. It's going to the right, then coming to the left. So the activity on the ventricle becomes wider. So it's a widened QRS because it's taking more time to reach the left ventricle. And there is an M wave on the QRS. Okay, the M wave on the QRS, particularly seen in lead V5, V6, and also lead 1. Lead 1 comes from there. So if you look carefully, this is not picking it up very well, but lead 1 will be a reverse M. Just like this is a small M here, the lead 1 will be a reverse M. It's not seen very well in this ECG. Okay, but V5, V6 is very representative. Also, the AVL is also looking at it from the left lateral, right? Remember that axis I showed you? So AVL is also looking from them. So look in the AVL, again in AVL you're seeing an M pattern. But predominantly V5, V6, left lateral. AVL is also left lateral. Lead 1 is also left lateral, but 1 is not really catching it very well in this particular ECG. This is classical sinus rhythm with left bundle branch block. Okay, did you understand conduction problems?
Yes, sir.
Yeah, is it clear
Yes,
now?
sir.
Yeah.
Yes,
So
sir.
there are only 5 things that you really need to know. First degree heart block, second degree heart block, third degree heart block, left bundle branch block, and right bundle branch block. Okay, 5 things. That's all. It's very, very easy. But it does give you a lot of credit in the exam when you can pick this up. And these are classical things. These are not difficult to pick up. If you see, you have to keep seeing a lot of ECGs before you become good at these things. Okay, all right. Let's look at P waves. There are some things of P waves that are an issue. What do you think a tall P wave means? What is happening in a tall P wave? Anybody wants to tell me what does a tall P wave mean? You know,
Atrial fibrillation is taking more time.
Not more time, but more strength. Isn't
More
it?
electrical activity in
More electrical
atrial.
activity. So what will cause more electrical activity in the atrium?
More
Atrial
stress on the
hypertrophy.
atrium.
No, more
Atrial
muscle.
hypertrophy.
More muscle.
More muscle. So there is more right atrial hypertrophy. Okay, tall T wave usually represents right atrial hypertrophy. And if it's a prolonged P wave, a broad P wave with a notch in between, that means it is taking more time for the SA to go across the left and the right. So it usually, when there's a broad P wave or there is a notched P wave, it usually represents left atrial hypertrophy. Okay, is it now making sense? Are you starting to understand what the textbooks tell you? Because you have now understood what is happening. What does the P wave represent? Okay, so let's look at some examples. Look at this one. There's a tall P wave, yeah, tall P wave. So more muscle mass. So because there is more muscle mass, this is called as right atrial hypertrophy. If you look at this one, look at this broad. The P wave is broad on the ECG, and there's a slight notch. Can you see that slight notch on the P wave? So the impulse from the right atrium is also being sensed, and the extra impulse, because left atrium is enlarged, there is extra impulse on the left side. So you're getting this notched P wave. Yeah, so this broad P wave and a notched P wave always represents left atrial hypertrophy. Okay, make sense? Tall P wave, right atrial hypertrophy. Broad P wave, left atrial hypertrophy. Okay, what do you think will happen in a ventricular hypertrophy? You can come in and tell me.
Depending on either right ventricular, left ventricular, it will
Yeah,
be.
but what will happen to the QRS?
It will be in tall.
Tall. So increased height of the QRS complex. Okay. So whenever the QRS complex is tall and high, there's increased height of a QRS complex, always think of ventricular hypertrophy. Now, if you want to look at the right ventricle, which is the best lead? Come on, guys. Right ventricle. Just get the orientation. Horizontal axis. Right
V1,
ventricle.
V2.
Yeah,
V1,
V1, V2. Very simple. So if there's right ventricular hypertrophy, the tall QRS will be in V1, V2. You agree or no? Simple. It's nothing complex. Okay. What do you think where do you look for left ventricular hypertrophy?
Lateral leads.
V5, V6. Yeah, V5, V6. Is it? So it's not very difficult as long as you have understood that it's coming towards and against, and you've understood which side the angle, the heart is being looked at. It's very easy to identify what is. So look at this. Tall P waves, yeah, a tall QRS. Can you see this tall QRS, V1, V2, and V3 as well? So that is usually right ventricular hypertrophy. Yeah. If you look at this one, look at this tall QRS and V5, V6. Can you see that they're so tall that they're crashing into the sign above? Yeah, this is left ventricular hypertrophy. Is it making sense?
Yes, sir.
It's very easy, very easy. It's not difficult at all. Okay. So what will happen if there's broadening of a QRS? What does that mean?
Some sort of
I showed you earlier.
Some sort of a conduction problem in the
Yeah, so there is an abnormal interventricular conduction problem, isn't it? We saw it in the previous one. So because it is taking more time for the ventricular depolarization to go across the septum into the right and the left, normally a broadening of a QRS complex usually suggests an abnormal intraventricular conduction. And the commonest broadening which we just discussed is which one?
bundle branch.
Excellent, bundle branch block. Okay, so bundle branch block is the commonest one which will cause you a very widened QRS. Okay, and it's also seen in WPW. All right. Okay, so does that make sense? Is it easy?
Yes, sir.
Yes, sir.
Okay, now let's look at ST segment. Okay, so let's look at it. Let me see how many more slides are there because we are coming to end of time. Slide 1, 2, 3, 4, 5, 6. Okay, I think we should finish this talk rather than stop at 7 o'clock. Is that okay with you guys, or do you want to stop at 7 o'clock? Just finish this. It's just the last part. These are now the important ones. The MIs are coming into the picture. So ST segment, this is normal ST segment. This is elevation and this is depression. Yeah. Okay. Easy. So whenever there's ST segment elevation, think about MI or pericarditis. Okay. Very, very easy. So whenever there's ST segment elevation, you must think about MI or pericarditis. Pericardial inflammation can also give rise to ST segment elevation. So sometimes in myocardial infarction, you might also get prominent Q waves. They're usually 1 centimeter across, 2 millimeters deep, and they will suggest that there is MI happening. Okay, so you've got to watch out for that very carefully. ST segment depression and T wave inversion usually suggest ischemia, which means that whenever there's ischemia, the ventricular depolarization cannot go across, and the repolarization is affected. So because that latent period increases, there is a prolongation of the ST segment. Okay, and also it can suggest ventricular hypertrophy because it's taking more time to depolarize and it is taking more time to repolarize. It can also suggest abnormal interventricular conduction problems, and sometimes dejoxing can cause these problems. Okay, so remember these are differential diagnoses for ST segment depression, but commonest one is ischemia. So ischemia will cause ST segment depression or T wave inversion. Okay, so let's look at T wave inversion. Now T wave inversion is normal in 3, AVR and V1. So as I told you earlier, look at the diagram, and as I told you earlier, the T wave, the negative starts to move away. Yeah. So because the negative moves away in lead 2, the negative is moving away from the positive of the lead 2. There is a upward deflection. Okay. So it is the repolarization which is represented as positive in lead 2. But that negative is moving towards AVR. Okay. So because it's moving towards AVR, there will be a negative deflection. So it will be inverted in lead VR and also in lead V1. V1 is looking at it from this side. So negative going towards a positive will cause an inversion. Okay, a negative towards a positive because it's a repolarization. It's not depolarization. So there will be inversion in VR. There will be inversion in lead 1, and lead 3 sometimes can represent as an inversion If it's a little twisted, the axis is a little deviated, then it can represent T wave inversion. It might be present in bundle branch block because there is a delayed delay of the conduction. It also represents ischemia, and it also represents ventricular hypertrophy. Okay, so these are the few things that you have to remember which will cause a T wave to be abnormal. A T wave flattening or a peak with an unusually long or a short QT intervals is usually electrolyte abnormalities, because P wave or the T wave predominantly depends on the potassium channel change closing. The sodium channel closing and the potassium starting to leak out. Okay, the repolarization is predominantly a potassium phenomenon. So whenever you have a problem with the potassium levels, then T wave is the first one which gets affected. Okay, the sodium you don't get so often, hyponatremia and things like that. But if you have a sodium problem, then you will have a problem with depolarization. If it's a potassium problem, predominantly the potassium problem represents itself as a T wave flattening or a peaking of the T wave. Okay, but minor changes are not specific, they are non-specific. So T wave, only the in association with the ST, it is a good technique to help you diagnose what is going on. So let's look at this ECG. Okay, it's in front of you. Have a look at it. Look at V1, look at V2, V3. Something is going on in V1 and V2. But more importantly, look at V4, V5. Okay, look at V4, V5. Oh, lots happening in V4. So sinus rhythm, rate of AT, axis is normal. You can calculate the axis if you want. Positive, negative, positive, negative. It's a normal axis. Lead 2 is isoelectric, so it's a normal axis. Small Q waves in 2, 3, AVF. Okay. So let's look into it. See this Q wave. So presence of Q wave in 2, 3 and AVF usually suggests an old infarct. Okay. So if there's a Q wave present, it usually suggests old infarct. But that's not the problem here. The more important problem is the elevation. Okay, look at this ST elevation. Okay, grossly elevated from the baseline. And whenever this elevation is V3 and V4, what do they represent? V3 and V4, anterior wall. Okay, so it is an acute anterior infarct that is happening. So V1, V2 represents septum. V3, V4 usually is looking at anterior, and V5 and V6 is usually looking at the left lateral. Okay, all right. And V7, 8, 9, if you want, will look at the posterior part of the heart. All right, let's look at this one. All right. So this one, if you look carefully, the rhythm is sinus. If you calculate the axis, there is actually a left axis deviation in this slide. Sorry about that. Left axis deviation. There is Q wave in VL, V2, and V3. Okay, and there's ST elevation in VL, V2 to V5. Look carefully. There is ST elevation. Yeah, there's something going on here. But it is being sustained through V4 and V5. Yeah. So this ST elevation, particularly in lead 1 as well. So lead 1 is showing it. VL, which is looking at the right side of the heart. Yeah. Which is looking at the left side of the heart is also showing this. And V2, V3, and going into V4 is anterolateral infarct. So there's anterior also, and it's going towards the lateral side as well. So there are changes all along. So it's an anterolateral infarct. So you've got to add more and more leads to make a diagnosis. But first, predominantly zoom into one lead, understand what's happening in one lead, and then add the extra leads to see whether is it extending beyond the anterior, going into the lateral. Okay. So look at this one. This one is sinus rhythm. The rate is 70. Axis is normal. There is Q wave in lead 2, 3, and VF. Yeah. Q wave formed. Where is my marker? So Q wave formed in lead 2, 3, and VF. Yeah. Something is going on there. QRS complex looks normal, but the ST is elevated in lead 2, 3, and VF. ST is elevated. Lead 2, 3, and VF. And if you look at lead 2, lead 2 is looking this way, lead 3 is coming from here, okay, and VF is looking, all of these 3 leads, lead 2 is at the angle of the heart apex and looking downwards, lead from the foot you're looking downwards, and from lead 3 also you're looking downwards. So this is more likely to be an acute inferior infarction, okay? It's an acute inferior infarction. This is inferior infarction. 2, 3, and VF is usually looking at the base of the heart. So this is a inferior infarction, okay? All right. Let's look at this one. Can you see this? Tell me what you're finding. Sinus rhythm, the rate is about 70 per minute when you calculate. The axis is okay, but in R wave, there is a dominant R wave in lead V1. The R wave is dominant in lead V1. There's a flattened in lead 1. Okay, the T wave is flattened. Yeah. And in VL as well, there's a problem. There's flattened. There's no T wave seen here. Can you see that? There's no T wave seen here. So this is usually a posterior MI, because 1 and VL are looking at it from the side, left lateral. So in this situation, what I will do is I will actually put lead 7, 8, and 9, okay? Because you cannot clearly see the ST changes, but you're seeing some flattening of the leads in lead 1 and lead 2. So there's a subtle hint that something is going on beyond the left lateral. So something is going on beyond. There's no T wave seen in lead 2, no T wave seen, sorry, in lead 1 and VL. So something is happening beyond the left lateral side. So in this situation, what I would do is I would put lead 7, 8, and 9. And when you put lead 7, 8, and 9, what you will see is ST elevation. So the ST, so this is ECG, which is giving you a hint that something is going on beyond the left lateral. So in a normal ECG, you're not able to pick up the ST elevation, but definitely T waves are lost here. So this is an indication for putting 7, 8, and 9. And when you put 7, 8, and 9, you will see ST elevation, and that will give you a diagnosis of posterior MI. Okay, let's look at this one. Okay, anybody wants to take it, or I'm happy to go through it. So the upper tracing is showing heart rate of 55. The ST is isoelectric, correct? The lower tracing is after exercise. Can you see that? So this is normal at rest, and this is after exercise. So at rest, he was okay. But the moment he started to exercise, there is depression of the ST. Can you see that? This is depression of the ST. So this is not infarcting, but this is ischemia. Okay, this is ischemia. So this is exercise-induced ischemia. So this is the way to identify the ST depression. Gives you an indication that there is ischemia in this patient when he's starting to exercise. Okay, so let's go through this one. The sinus rhythm, rate of 62. Axis is normal. QRS is normal. There is some inversion in T wave, in V2, in V3 and V4. See this? V4 T wave is starting to get inverted, okay? And actually, there is biphasic waves in V2 and V5. So V2, look at this. Can you see this? Biphasic wave in V2 and also in V5. There's a biphasic wave, T and a depression, okay? So this is again suggesting to you that there is some problem with the myocardium, but there is no elevation of the ST. There is no elevation of the ST anywhere. So there is no ST elevation, but there is definitely some problems with the repolarization here. Can you see that? The repolarization is affected. Something strange is happening here. And this is, again, a classical indication of non-ST elevation MI. Okay? So when you get inverted T waves in V3, okay, that's important to understand. Inverted T waves or biphasic T waves are an indication that you are actually having an MI, but this is called as a non-ST elevation MI, okay? And because this is happening in lead 2 and 3, okay, and 4 as well, more likely to be anterior. The area that is being affected is the anterior part of the chest wall, of the myocardium. So this is anterior part of the myocardium, and it is going towards the lateral as well, starting to go towards the lateral, because V5 is also starting to show some biphasic changes in the T wave. Okay, so this is the way you pick up. Now this is another one which I will just talk about it. Where am I? I can't even see it. This is classical of pulmonary embolism, and this is something which you just have to see a few of these. I want you to see a few of these before you can answer this. So I put this slide up there for you. Go back to any internet site and look for pulmonary embolism. And when you look for pulmonary embolism, you will always get right axis deviation because the right side is affected. There's right arch strain because the embolus has gone into the pulmonary artery. So the right ventricle is straining against blood clot in the pulmonary artery. So you will get right axis deviation, a tall peak T wave. Look at this T wave. So this is indicating that there is something wrong with the right atrium, okay? There's a problem with the right atrium. Either there is a hypertrophy or there is increased strain. So a tall peaked T wave on the right atrium and a persistent S wave in V6. Look at this persistent S wave in V6. All of this suggests that there is a problem with the myocardium. Again, a T wave inversion. Look here, T wave inversion in V2, V3. So this heart is having some trouble pumping the blood against a clot. There's something that is stopping, and most of it is predominantly on the right side or on the septum. So V1 is also showing a change. V2 is showing a change. So a right arch strain, a right axis deviation, a tall peak T wave, all three put together is equal to pulmonary embolism. You need to see a few of these to actually identify these, okay? So it's very, very important that you keep seeing a few to identify. Now, just quickly, 3 or 4 slides, quickly to look at revision of what we have discussed so far, just 3 or 4 slides, okay? So let me just tell you, so depolarization starts in the SA node, spreads to the ventricular via the AV node, the bundle of Hayes, the right bundle and the left bundle branch, and then anterior and posterior fascicle of the left bundle branch. I have not put in the anterior and posterior fascicle ECGs. These are all more complicated for cardiologists to understand. For us as surgeons, we just need to be able to identify MI. We need to be able to identify what is the region of the MI that is a problem. We need to be able to identify whether the septum is a problem. We need to know whether there's a conduction block. We need to know whether it's a right bundle branch block or a left bundle branch block, or if it's a first degree or second degree or third degree block. And then the rhythm problems we need to be able to identify. Atrial fibrillation, atrial flutter, ventricular tachycardia, and ventricular fibrillation. These are the main rhythm problems. And the one extra we put in is called as WPW, classic findings on these things. So that's why I put that extra in there. So not, you really don't need to go into the details. We said that the septum depolarizes from left to right. Always lead V1 looks at the right ventricle, V6 looks at the left ventricle. When depolarization spreads towards an electrode, the stylus moves upwards. If the conduction is normal through the AV node, the base and one of its branches, and it is abnormal in the other branch, then the QRS complex becomes wide. We did that earlier in the thing. Conduction problem in the AV node and his bundle may be first degree or second degree or third degree, okay? Thank you very much. Now I've got about 30, 40 ECGs, which I don't think I will show you now, but this is for another revision lecture where I will show you the ECG and you will diagnose for me what is the problem. So my first point was to give the lecture, and then next point was when we discuss in another session, I can throw the ECG at you, and I want you to look at the ECG and I want you to tell me what is the diagnosis. Okay? All right. Thank you very much, guys. Let me just stop share.